Hi there. I'm Dr. Brian Letworth from the Scottish Centre for Respiratory Research, Nightwells Hospital, Dundee. And this is a talk which I gave a week ago at the American College of Allergy, Asthma and Immunology at their annual virtual meeting on the 13th of November, which I'd like to share with you. So this first slide shows the way that I think about COVID-19, which manifests as a viral-induced cytokine-mediated form of autoimmune disease. And that in turn is characterized by hyperinflammation and associated coagulopathy, which leads to severe outcomes in addition to COVID pneumonia, and ultimately a need for mechanical ventilation, and in some cases, fatality. If we're thinking about how the SARS-CoV-2 virus enters into the host, I think it's germane to think about the seed in the soil. In other words, looking at the ACE2 entry receptor and the associated viral load. So basically, the TMPRSS2, which stands for transmembrane protein serine 2 receptor, this primes the spike protein on the virus, and that in turn then hitches a ride into the host respiratory epithelial cell, initially in the nose, later in the lower respiratory epithelium. And it hitches a ride via the angiotensin converting enzyme 2 receptor and is then endocytosed into the cell. So it's worth bearing in mind in terms of the increased expression of ACE2 receptors that this can occur in association with smoking in males, in association with testosterone levels, more so in adults than in children. Also increased expression in diabetics, and also in drugs such as angiotensin converting enzyme inhibitors and angiotensin receptor blockers. This next slide depicts the clinical stages of progression of the COVID-19 disease process. So in the early stage of the infection, you get constitutional symptoms like fever, a dry cough, and also the presence of lymphopenia. Later on in the disease, when it infects the lungs, you then get, in addition to cough, you get shortness of breath if the patient's hypoxic, with a PO2, with a oxygen saturation less than 92%. That will be associated with lung infiltrates on chest imaging, on a chest X-ray or high-resolution CT scan, along with involvement of transaminitis with raised liver enzymes, such as alanine transaminase. Later on, once the host inflammatory response kicks in, which is due to release of cytokines, that can then lead to elevated inflammatory markers, including IL-6, CRP, LDH, D-dimers, ferritin, troponin, and pro-BNP. They all become elevated. In turn, these patients are at much higher risk of developing ARDS, shock, and cardiac failure. The point I want to make, first of all, is that SARS-CoV-2 infection usually begins in the nose, and that's why 40% of patients present with anosmia and loss of taste. What happens then after the virus gets a foothold in the nose, in the nasal respiratory epithelium, it then becomes aspirated and then starts to infect the lower respiratory tract, leading to the typical symptoms of COVID pneumonia. And this was a study by Hu et al. In Cell, which showed that the expression of ACE2 is actually much higher in the proximal airway in the nose than it is in the distal airway in the lung, and associated infectivity with SARS-CoV-2, at least initially in the disease, is also much higher. The other point, as I've already made, is that older people have much higher expression, at least in the nose, for ACE2. And this is a paper in JAMA, which looked at the ACE2 expression. And as you can see, in children under the age of 10, expression of ACE2 is much lower in the nose than it is in older adults. So what are the risk factors for death in people who contract COVID-19? And probably the best data and the largest database from over 17 million adults is from the UK Open Safely database, in which there were over 10,000 COVID-19 deaths. So in this slide, here we show the adjusted hazard ratios, and in brackets, the 95% confidence intervals for hospital-related COVID-19 deaths. So, first of all, in patients with asthma, there is no increased risk of death in patients who were not taking oral corticosteroids, OCS, but in more severe asthma patients who were taking oral steroids, you can see the hazard ratio was increased by 13%, and the lower end of the confidence interval, 1.01, excluded unity. So more severe asthma patients, especially those taking oral steroids, appear to be more prone to a fatal outcome when they get COVID-19. It's worth also highlighting other risk factors and other comorbidities. So the risk of death sharply increases above the age of 60, as you can see, also in people with Black ethnicity, people who are obese with a BMI greater than 40, diabetics with an HbA1c above 58, patients with chronic kidney disease with an EGFR less than 30, and patients who have COPD are also at increased risk. So what are the predictors of a severe outcome in COVID-19? And this is a cartoon that we made up for an editorial in the Journal of Allergy and Clinical Immunology in Practice earlier in the year. So as you can see, the SARS-CoV-2 virus, as I said, hitches a ride via ACE2 into the respiratory epithelium. This is followed by a cytokine cascade or storm involving the release particularly of IL-1, IL-6 and TNF-alpha. That results in the hyperinflammatory syndrome, and patients who have COVID pneumonia and ARDS become hypoxic. Interleukin-6 in turn promotes hepatic synthesis of C-reactive protein, CRP, and also the hyperinflammatory cytokine state results in coagulopathy, which is associated with raised D-dimers. So the presence of raised D-dimers, raised IL-6 or CRP, and the presence of hypoxia are all important predictors of a worse outcome in patients with COVID-19. And these are some data that I published in collaboration with some colleagues in Munich in the Journal of Allergy and Clinical Immunology. Harold was the first author on this paper, which showed that circulating levels of interleukin-6 during the COVID illness is a strong predictor of impending respiratory failure in patients who present to hospital with severe COVID-19 pneumonia. And you can see very clearly here that the maximal levels of interleukin-6, both in the initial evaluation cohort and in the subsequent validation cohort, are clearly separated in those needing mechanical ventilation compared to those who did not need ventilation. And for IL-6 levels greater than 80 picogram per mil, the receiver operating curve showed an AUC of 0.97, and in turn, maximal values of CRP during the illness, which were greater than 97 milligrams per litre, had an AUC of 0.86, so very highly predictive. The ISARIC-4C collaboration also looked at a mortality score to stratify risk of patients admitted with COVID. And these are the factors that were incorporated into the score: age, gender, comorbidities, respiratory rate, oxygen saturation, Glasgow Coma Scale, urea, and CRP. And basically, the higher your score value, the more likelihood you are of dying from COVID-19. So if we're thinking about how the SARS-CoV-2 virus enters the airway epithelium, these are some data published by Jackson in JCI earlier in the year, looking at the allergic asthmatic children and airway epithelium. What they showed very elegantly is if you look at asthmatic kids, then the expression of ACE2 is reduced in proportion to the degree of atopic or IgE sensitization. So the more atopic the kids were, the lower the expression of angiotensin 2. And in turn, you might expect that if you've got reduced expression of ACE2, that would lead to less of the virus entering the respiratory epithelium. This next slide looks at the differential regulation of the two COVID entry receptors, namely ACE2 and TMPRSS2, in epithelium of asthmatic subjects. And here we look at healthy subjects, those with type 2 low disease and those with type 2 high disease. And you can see here that while the expression of ACE2 in T2 high individuals is reduced, in contrast, the expression of TMPRSS2 is upregulated in the same individuals with type 2 high disease. And the reason for that, the mechanism, is related to interleukin-13, which is one of the key pro-inflammatory cytokines in Th2 inflammation, along with IL-4 and IL-5. And you can see here, this is ex vivo data looking at what happens to these receptors after exposure to IL-13 in airway epithelium, that stimulation and exposure by IL-13 results in downregulation of ACE2, but in turn upregulation of TMPRSS2. So it's the IL-13 that's driving this differential SARS-CoV-2 receptor entry expression. So you might think in turn, because IL-13 is responsible for FeNO production in asthmatic patients, I think it's intriguing to speculate whether asthmatic patients with a higher level of FeNO might also have the same expression of their SARS-CoV-2 receptors in terms of reduced expression of ACE2 in association with raised FeNO. And I think that's something which is worth looking at. The other interesting observation is that inhaled corticosteroids also appear to suppress expression of these SARS-CoV-2 entry receptors. So inhaled steroid, as you can see, in dose-dependent fashion, results in reduced expression of ACE2 and reduced expression of TMPRSS2, but in contrast, has no effect on ICAM1, whereas ACE2 and TMPRSS2 are involved in cell entry for SARS-CoV-2. ICAM1 is involved in entry of rhinovirus. So there you have a very nice negative control. And this table very nicely illustrates the heterogeneity and potential risk of severe COVID-19 in patients with asthma. And I've highlighted here, as you can see in red, that the increased risk of COVID-19 is associated with patients who've got type low asthma, in other words, patients with low FeNO, low eosinophils, or low IgE. More severe asthmatics have an increased risk of COVID-19, as you saw in the open safely cohort. So these would be GINA step 4, step 5. And as you saw also from the open safely cohort in Nature, severe asthmatics who require maintenance oral steroids or frequent courses of oral steroids are also at higher risk. So those are the patients that you might want to particularly shield in terms of COVID-19 risk during the pandemic. So that moves us on to look at the potential pharmacological targets for treating COVID-19. And this was a figure that we published in an earlier editorial in JACI in Practice. Now, it's a little bit busy, I appreciate that, and I'm not going to go into all of the different targets. But what I would like to outline here is the potential effects, in particular, of corticosteroids in terms of their effects on key effector cells, including CD4 cells, and in turn, the effects on pro-inflammatory cytokines. Because as you know, corticosteroids will suppress a variety of cytokines, and here showing their effects on IL-1, IL-6, and TNF-alpha, which are particularly involved in the hyperinflammatory response in COVID-19. I'm not going to go into any detail in terms of vaccines, but I'm sure you've all read the press in terms of preliminary phase 3 efficacy results for these 3 vaccines, which seem to have efficacy rates in excess of 90%. And we wait to see the peer-reviewed literature, and hopefully these vaccines will get approved for emergency use in the future once we know that they are also safe to administer. So this is very encouraging data, but I'm not going to go into the vaccine story in any more detail. In terms of proven drugs which reduce deaths in severe COVID-19, so this is data from randomized controlled trials, this is where we are at the moment. And really the strongest data thus far has been for the glucocorticoid dexamethasone, which came from the recovery trial, which I will dig deeper into in subsequent part of the talk. And really that's the only data, strong data in my humble opinion, which has shown any effect from randomized controlled trials. Just yesterday, actually, data came out from the REMAP-CAP trial. These are data from patients undergoing critical care treatment for COVID, which suggested that the anti-IL-6 agent tocilizumab seemed to have a benefit in terms of reducing severe outcomes in patients, critical patients with COVID-19. Having said that, previous trials, like the COVACTA trial, did not show any benefit of tocilizumab in patients with severe COVID-19. So the jury's out on that, and we really need to see in detail the peer-reviewed data from REMAP-CAP, and in particular, I think what we need to see is whether the effect of tocilizumab is seen in addition to patients receiving corticosteroid therapy with either hydrocortisone or dexamethasone. But other drugs haven't shown a benefit. So that's why I've put a cross opposite remdesivir, no impact on mortality, although it does shorten the duration of illness, no effect of hydroxychloroquine, azithromycin, antivirals like lopinavir and ritonavir, no effect of interferon, seen in the Solidarity trial, no effect on mortality of convalescent plasma. I've put a query next to the Regeneron antibody cocktail, because although it does shorten illness, it hasn't been shown yet to have an effect on mortality. I've also put a question mark next to heparin, because although it obviously has an effect on coagulopathy and thromboembolic events, we don't know whether it actually has an effect on the SARS-CoV-2 virus per se. So just digging further into the UK recovery trial, this was looking at mortality in hospitalized patients with COVID-19. So here we have the figure from the New England Journal paper looking at 28-day mortality. And the bottom line is that the effect of dexamethasone was only seen in patients, the beneficial effect in those on oxygen, where the number needed to treat was 35. In other words, you need to treat 35 patients who are receiving oxygen to prevent one death. The number needed to treat was better in patients who were more severely ill, who were ventilated, where the number needed to treat was 8. This is an interesting post-hoc analysis of the recovery data, which was in the supplement of the New England Journal paper. I think this revealed some interesting findings which may not be that well disseminated, which I've highlighted in the red box, and that is that there is no benefit from dexamethasone in the recovery trial in those who were over 70, female participants, those within 7 days of having symptoms, and also, as I've already said, no benefit was seen in those who weren't receiving oxygen or weren't being ventilated. And this is a meta-analysis performed by the WHO, published in JAMA, looking at mortality among critically ill patients with COVID who were receiving corticosteroids from randomized controlled trials. And I'm not going to walk you through this because it's a bit busy, but the take-home message is that the overall number needed to treat was 12. So you need to treat 12 patients to prevent one death with dexamethasone. And that was 7 randomized controlled trials in 1,700 patients. Moving on to the other large trial, which is the WHO Solidarity trial. It's not been peer-reviewed yet, but it has been published as a preprint on medRxiv, and this is where this particular graph is taken from. And this showed no benefit compared to usual care as controls with either remdesivir, hydroxychloroquine, lopinavir, ritonavir, or interferon. The WHO then went on to publish a meta-analysis of remdesivir on mortality in hospitalized patients. And the bottom line is there is no benefit, as I've already said. In fact, the overall number needed to treat was 143 from this meta-analysis. If we're looking at topical corticosteroids, then there's some interesting data, albeit only published as a preprint. And this showed that certain corticosteroids, namely ciclesonide and mometasone, at least in vitro, appears to suppress replication of the SARS-CoV-2 RNA. And this wasn't seen with other corticosteroids. Interestingly, it wasn't seen with fluticasone, wasn't seen with beclomethasone, wasn't seen with budesonide, and it wasn't seen with dexamethasone. So the beneficial effect of dexamethasone in recovery, I think we can attribute to suppression of pro-inflammatory cytokines, but it doesn't suppress viral replication. And presumably that's why you don't see a benefit of glucocorticoids if they're given within 7 days of symptoms. It's only once the hyperinflammatory cascade has started to kick in that you see the benefit. But of course, this raises the intriguing possibility that perhaps giving topical corticosteroid by the inhaled, and I would also suggest the intranasal route, particularly mometasone and cyclesonide, might be useful, for example, in post-exposure prophylaxis in vulnerable, susceptible elderly patients with comorbidities. And this is a slide which I published in Annals of Allergy in 2020, just trying to highlight the benefit risk of inhaled steroids in SARS-CoV-2 infection in asthmatic patients. So the first benefit might be the specific effect of cyclesson-ibometazone, which occurs through non-structural protein 15 to suppress replication. That's not been proven in vivo yet. You already know that inhaled corticosteroids suppress expression of ACE2 and TMPRSS2. They also suppress pro-inflammatory cytokines. That's how dexamethasone works in the recovery trial. They melt away eosinophils. That's why they're effective in asthma and allergic rhinitis. In contrast, they might have adverse effects in terms of promoting bacterial overgrowth, and also might have adverse effects in terms of suppressing endogenous cortisol from the adrenal gland. But then again, they might have beneficial effects by suppressing release of aldosterone. And what about the use of inhaled corticosteroids in asthma and COVID-related deaths? So again, this brings me back to the Open Safely study published recently in the Lancet Respiratory Medicine. This was in over 800,000 asthma patients. And what they looked at was the adjusted hazard ratio, and in brackets, the 95% confidence interval, comparing inhaled steroid against SABA use alone. So if we look at low to medium dose inhaled corticosteroid, although the hazard ratio, the point estimate exceeded unity, it was 1.14, it wasn't significant. And that's because you can see the lower part of the confidence interval included unity. The lower CI was 0.85, so it was less than 1. In contrast, in patients receiving high-dose inhaled steroid, the hazard ratio was 1.55, and the lower confidence interval excluded unity. So by definition, that was a significant effect in terms of an increased risk of COVID death. So does that mean per se that higher doses of inhaled corticosteroid increase the risk of COVID death? Well, the problem here is that we have confounding by severity, because more severe patients obviously were taking higher doses of inhaled steroids. So the authors of the study interpreted this as being an effect of confounding by disease severity. In other words, more severe asthma patients are at a higher mortality risk for COVID-19. So just to wrap up now, the first key point I'd like to make is that the nose is usually the first portal of entry of the SARS-CoV-2 virus, where there is higher ACE2 expression and also higher viral infectivity in the early stage of the illness. Older, obese, male, type 2 low, more severe asthma patients who smoke with comorbidities are more prone to severe COVID-19 outcomes. There is encouraging, albeit preliminary, vaccine data from the Pfizer, Moderna, and Sputnik vaccines, which appears to show more than 90% efficacy. Dexamethasone reduces deaths for late phase severe COVID. And that's really the strongest data thus far from large-scale randomized controlled trials. I think what we need are widely available cost-effective treatments for early phase COVID to prevent disease progression in susceptible individuals, for example, for post-exposure prophylaxis. And I think this preferably should be given by both the inhaled route and the intranasal route to ensure the greatest degree of efficacy. But finally, what I would suggest is that for your patients with unified allergic airways disease, in other words, patients with asthma and allergic rhinitis, that as clinicians, we should focus on achieving optimal anti-inflammatory control of the unified allergic airway in order to get the best possible outcomes for our patients and improve control in the upper and lower airway of patients with asthma and allergic rhinitis. And in turn, this is most likely to protect against any viral stimuli, possibly including SARS-CoV-2. So thank you for watching this video today. In particular, I'd like to thank the American College of Allergy, Asthma and Immunology for inviting me to give the talk, and I hope you learned something from this today. Stay safe and have a great weekend.